Thank you, and appreciate the opportunity to talk about some emerging and really interesting concepts that we're now applying to the management of aortic valve disease in younger patients in particular. So when we look at aortic valve disease in the younger patient, I think our thinking is really changing away from what we've been thinking about the last 10 years or 15 years in the TAVR era about risk, low risk, intermediate risk, high risk, into life expectancy. So what decisions do you make about a patient who needs to live another 20 years, 25 years, or 40 years? And I think we're really entering this era of age-related decision making and integrating into it all these new treatment algorithms we have, like valve-in-valve TAVRs and some emerging areas where we're looking at mechanical aortic valve replacements with DOAC. So a lot of the classic ways that we think about aortic valve replacement, especially in younger patients, are really evolving. One of the things I think we are really developing a good understanding of now, though, is that our current ways of treating the aortic valve with our traditional prostheses, mechanical or tissue, really are deficient. That this is data that shows from the New England Journal by one of our former fellows that shows that, in fact, when you look at patients who are younger, typically if you're less than 55, you do better with mechanical. Older than 55, tissue is a good alternative. But the actual mortality of these patients at 10 to 15 years was almost 30%. So we're not, we can't tell these people that fixing their aortic valve is going to, kind of bring them back to normal life expectancy again. It's not. These are really inadequate solutions we have. And what we really need is a more physiologic solution. And this is where the Ross procedure, which is traditionally more thought of as more of a congenital heart surgery operation, is something that we are applying more and more to younger adults and younger patients with aortic valve disease. It's a procedure where we take the patient's pulmonic root, so the pulmonary artery and valve, and put it in the aortic position. So we're moving from the right side, the low pressure side, to the left side, high pressure side. And that's their new aortic valve and root. And then we use a cryopreserved homograft, a cadaveric tissue, to replace the pulmonic root and pulmonic valve. Low pressure, we think that it can be durable in that situation. Potential advantages of the Ross, incredibly natural gradients. It is a natural valve. There's nothing obstructive about it. Very good durability, and we'll go into that in a little bit. But it's a living valve. It has cells in it that are still alive, and it functions exactly the way our valves do, including getting larger during systole when we're exercising. So they actually give young patients a really good exercise capacity. So these are some of the reasons that we become much more interested in the Ross operation, but there are some potential problems with the Ross. It's a more complex surgery. I think in the hands of experienced surgeons who do a lot of root replacement surgery, it's something that's certainly within our wheelhouse. But it does potentially create two valve problems instead of one. So you have a pulmonary homograft and you moved the actual pulmonic valve to the aortic position. You can have attrition of the pulmonary homograft that can happen either at the conduit level, which is actually quite common, that can calcify and narrow, or at the valvular level. And the autograft itself can dilate. This is you're taking something that's designed to have a systolic pressure in the 30s and putting it in the systemic circulation. It can stretch and dilate over time as well. But in experienced hands, overall, the rate of reintervention in a Ross operation on either side is less than 15% at 15 years. And that's using techniques I think we've actually gotten better with now than in the past. So what is different about the modern Ross? Why are we interested in doing it again all of a sudden? Well, all the potential failure modes of the Ross have in one way or another been addressed. We've figured out ways to eliminate all of the pulmonic root tissue. So we used to leave a lot of pulmonary artery in there, a lot of pulmonic root muscle in there, all gone. We just leave the valve and just a little bit of the sinuses. We reinforce everything at the annular level and at the sinotubular junction. So there really isn't a lot of room for this thing to grow. And we have a very strongly supported pulmonic root in there, autograft in there. We also use a decellularized pulmonary homograft. We put big ones in. These tend to not stenose. They tend not to have immune reactions. We also use NSAIDs post-op and really strictly control people's blood pressure. So when you put that pulmonary autograft in the high pressure scenario, that you're not loading it unnecessarily, causing it to stretch and dilate, because most of that actually happens in the first 3 to 6 months. We started our Ross program about a year ago, just over a year ago now, and we've been very active, very busy with it. Part of it was because we learned better implant techniques. We had better homografts. We have ways of intervening on the pulmonic valve without opening the patient up again with TAVR-like technology. And most importantly, the Ross really is the only aortic valve therapy that can return a person to their normal life expectancy. This is brand new data from New York State and California State, which shows that you see the black dotted lines at the bottom, the general population and the Ross operation patients have the identical 15-year survival rate. Mechanical and tissue valves, not the same, much worse. We put together a really strong program of anesthesia cardiology, specialist surgeons, only a couple of us do this, and advanced ICU services to make sure that we can manage these patients well, and we follow them very closely in our postoperative clinics. And today we're offering this operation to people who are under 60, typically, who have non-repairable pathology. Again, if we can repair the valve, that's almost always better, and we will repair. But stenosis patients, endocarditis patients, failed bio-AVR patients, all patients are candidates for the Ross. And we will extend it to aneurysm patients as well, as long as they don't have connective tissue disease like Marfan syndrome. And this is just an example of one of these cases where a young person had a congenital bicuspid aortic valve, had a tissue valve done in their 20s because they didn't want to take anticoagulation. Came back with a failed bioprosthetic valve at 7 years, and this is our pulmonic autograft being put in here. This is a pretty complicated case, a redo. There was a bit of an aneurysm, which we replaced as well, and that's the final product, and a really nice, perfectly functioning, natural-looking valve, which is absolutely great. And so we're excited to offer this procedure to our younger patients, and I look forward to the discussion about the management of aortic valve disease in this group. Thank you.